visible. Sir, please
Okay.
start.
Yeah. So good evening to everyone, and I thank the Bangladesh Society of Echo for giving me the opportunity to participate in this wonderful meeting. Multivalvular disease is a entity which we come across on daily basis. It presents to us several diagnostic and therapeutic dilemma, and I'll give you an example here. This is an elderly patient, and he was being evaluated for potential TAVR. As we can see, aortic valve is hardly opening, appears to be severe AS. However, the gradient was not high. A mean gradient was 25, suggesting low gradient severe AS. And this low gradient was largely because of extensive mitral annular calcification and mitral stenosis this patient had. So already we have a diagnostic challenge regarding the severity of AS here. But not only diagnostic challenge, we have a therapeutic dilemma as well, because now we need to decide what we have to do about this mitral valve. And since we are unable to do anything for this kind of mitral valve disease, will doing only TAVR be sufficient? So these are the questions that we need to answer in our daily clinical practice when we encounter multivalvular disease. And multivalvular disease is quite common. If you look at the overall population, it's been reported that roughly 15% patients have multivalve disease. This is data from the Euro Heart Survey. But the disease that we encounter more often, that is the rheumatic heart disease, in which multivalvular disease is much more common. As we can see here, data from the REMEDY study, which included more than 3,000 RHT patients. Here, more than 60% patients had moderate to severe multivalve disease. So for us, dealing with multivalve disease is almost a daily routine. So in patients with multivalve disease, the diagnostic challenge occurs because hemodynamic impact of the lesions is quite variable, depending on a number of factors, like which valve lesions are there, what is the etiology of valve lesions, what is the severity of each lesion, duration of the valve disease, loading conditions like blood pressure, and how the ventricle, especially left ventricle, has responded to those changes. So all these determine the overall hemodynamic impact of the valve lesions, and that determines the accuracy of various diagnostic criteria that we use. There's one basic principle in the assessment of multivalve disease by echo, and that is anatomic assessment is more reliable than Doppler assessment. So whenever we have doubt, we need to rely more on anatomic parameters than on the Doppler parameters. Now, similarly, we have a therapeutic dilemma also, again, because of a number of reasons. We need to see what is the overall hemodynamic effect of all the valve lesions. What are the treatment options? Can these lesions be treated percutaneously, or surgery is the only option? What is the added surgical risk of combined procedure? What are going to be the PHP related complications if the patient undergoes double valve replacement? And if we don't do this double valve replacement, what are the chances that the patient will need another surgery in near future? And if there's another surgery, what are the risks associated with reoperation? So all those things need to be taken into consideration when we decide about management of multivalve disease. But again, there are some basic principles here. If we have two valve lesions, which are both severe, then treating both of them together is generally recommended. And because this may be associated with high surgical risk, there may be a role for transcatheter procedures, if possible. If one lesion is severe and the other is non-severe, then the management is guided by the severe lesion. We should decide about the intervention, assuming that we only have one severe lesion, and we go by the guidelines, and the decision about the second valve lesion is to be taken case by case. On the other hand, if both the lesions are non-severe, then it has to be individualized for each given scenario. So with this background, we will look at some of the combination that we see. One of the most common combinations is aortic stenosis and mitral regurgitation. It can occur either because of degenerative involvement of both the valves. It may be a result of rheumatic heart disease, and many a times it may occur because there is severe aortic stenosis, which has resulted in LV dilatation and dysfunction, which leads to functional mitral regurgitation. When these two conditions coexist, MR interferes with AS assessment by reducing the transvalvular gradient. So we see low flow, low gradient AS more often. And here we cannot rely on gradient. So we need to look at aortic valve area. And we may have to use dovitamin echo for contractile reserve. Aortic valve calcification assessment using MDCT is another good tool in assessment of AS severity. On the other hand, AS increases severity of MR because there is high LV pressure, which increases MR jet. So mitral regurgitation jet area is not reliable. However, we can rely on vena contracta, ERO, and volumetric methods. They will also have some fallacies, but they are still better than jet area. When patients are treated for aortic stenosis and only isolated only AS is treated, then many times MR regresses after surgery, but not in every patient. So what are the factors which determine that MR will not regress? So as we can see here, if patient has 2+ or more significant functional MR and has one of these 4 risk factors, that is LA is significantly dilated, there is atrial fibrillation, and aortic stenosis does not have very high gradient. So in these cases, there are high chances that the MR will remain after the surgery. And when MR persists, it is associated with significant increase in the late adverse outcomes. So therefore, when these risk factors are present, then in AS patients, we should treat functional MR also. In case of TAVR, again, the similar situation occurs. TAVR also causes resolution of MR to a good measure, almost 50% reduction occurs, but in remaining 50% cases, MR persists, and in TAVR patients, degenerative MR is more common, and studies have shown that residual degenerative MR of any severity is associated with increased risk of adverse events over 1 or 2 years. Now coming to AS and MS, this is a combination which we see very often because of rheumatic heart disease. In degenerative heart disease, this combination is not that common because mitral stenosis, because of degenerative region, is usually not that severe. But when the two conditions coexist, again, mitral stenosis causes AS to become low gradient. That is one problem, and therefore we need to again rely on dobutamine echo and CT aortic valve calcium score. MS assessment also becomes challenging because AS is there, so there is LVH which compromises LV compliance, so PHT becomes unreliable. It may also cause a reduction in transmitral gradient, so we may see low flow, low gradient AS, and therefore we need to rely on anatomic assessment, that is direct planimetry using 2D or 3D. AR and MR is another combination which we can come across. It may be functional due to annular dilatation resulting in mitral regurgitation in a patient with severe AR, or both the lesions may be organic, either because of rheumatic heart disease or myxomatous degeneration or connective tissue diseases. Unfortunately, this combination is tolerated very poorly because there is double volume overload on the left ventricle, and that results in significant LV dilatation and dysfunction. It's been shown that these patients have much more LV systolic dysfunction prior to surgery, and post-operatively also there are high chances of residual LV systolic dysfunction and worse outcome. How the assessment is affected? So when significant MR is present in a patient on AR, volumetric methods become unreliable because we can't use mitral inflow for continuity equation, so we will have to use RVOT forward flow. PHT becomes unreliable because there is rapid LV filling which shortens AR PHT. Vena contracta may be reliable. Again, anatomic assessment comes for help. On the other hand, MR assessment also becomes challenging. Once again, we can't use volumetric method such as continuity equation. We will have to use RVOT flow, and therefore we will the alternative will be PISA, which still remains applicable. And in these patients, assessment of LV systolic function also becomes complicated. We can't use EF for assessment of LV systolic function. GLS may be more helpful. Then the combination of AR and MS. This is something which we see very routinely because of rheumatic heart disease. And we know that nearly 1/3 of the patients with MS have aortic valve involvement, and most of them have aortic regurgitation. So when MS is present, it blunts the volume overload created by AR. So LV dilatation is not that impressive. Peripheral signs of AR get masked and they become unreliable. So vena contracta or jet width is the parameter that will be more helpful here. AR also affects assessment of MS. PHT is unreliable in these patients. Many times AR jet hits the mitral valve and impairs mitral valve opening, so that may also complicate assessment of mitral stenosis severity. Continuity equation we cannot use because of unequal flows. So ultimately, we will have to rely on direct planimetry using 2D or 3D. And lastly, the combination of mitral valve disease with tricuspid valve disease, again a very common combination that we encounter in patients with mitral valve rheumatic heart disease, whether it is MS or MR, that leads to pulmonary hypertension leading to secondary TR, which is a very common occurrence. Now, TR itself does not interfere with assessment of MS or MR unless TR or TS lead to reduced RV outflow or RV cardiac output. Only then they will interfere with the assessment of mitral valve disease. There has been a common understanding that in these patients, when we treat the mitral valve disease, TR will improve with time automatically, but that is a big myth. TR spontaneously does not improve if annular dilatation has already occurred, significant annular dilatation. And a number of studies have shown that treating only mitral valve disease results in persistent and even late worsening of tricuspid regurgitation, which leads to several problems. Here we have a study in which patients who had chronic severe mitral regurgitation, they were undergoing mitral valve repair. If the investigators found that the tricuspid annulus was significantly dilated, they did tricuspid annuloplasty. In other patients, only mitral valve repair was done. So even though these patients who underwent tricuspid annuloplasty were sicker, their outcome was better long-term outcome.
Left to finish the lecture, sir.
Yeah, in a minute. And even in TAVR, the same situation is seen. If there is residual TR, it is associated with worse outcome. And that is the reason why the current guidelines emphasize on tackling TR at the time of mitral valve surgery if there is annular dilatation. So even if it is mild to moderate TR, if annulus is dilated, we need to treat it. And how do we define annular dilatation? Anything more than 2.1 centimeters per meter square is considered to be dilated tricuspid annulus. These two tables summarize the effect of all these valve lesions on each other. I will skip them. So to summarize, multivalvular disease is common, especially in our region with high prevalence of rheumatic heart disease. The overall hemodynamic impact and the net clinical practice are quite variable. Assessment of severity of individual lesions is often quite challenging. Anatomic parameters are better than Doppler parameters. And lastly, it also presents major therapeutic challenge because both under treatment and over treatment of the second lesion is quite problematic and leads to adverse outcomes in the future. Thank you so much.